going to start off the presentation. I'm Madeline Lasell, and of course I am joined by my colleague Susan Mills-Tucker.
Hello.
We both represent Beaufort, Jasper, Hampton Comprehensive Health Services here in South Carolina. We are registered dietitians who provide nutrition counseling and diabetes self-management education for our patient population. So today we'll discuss how Beaufort, Jasper, Hampton Comprehensive Health, or BJHCHS for short, has integrated diabetes self-management education into our primary care setting. We provide an array of health services for our patient population, including those diagnosed with diabetes. We are a federally qualified health center and a network of patient-centered medical care homes built with underserved individuals in mind. Originally, we were created to deliver services to the socially and economically challenged residents of Beaufort and Jasper counties here in South Carolina. And we became incorporated in 1969 and expanded in 1999, 30 years later, to include Hampton County as well. We provide our services among 8 medical centers and 9 school-based health centers within Beaufort, Jasper, and Hampton, which, if you aren't familiar with these already, are the 3 counties at the southernmost tip of South Carolina. And access to medical care in this region can be limited due to the rural nature of the area. On this next slide, you'll see photos of our 8 clinics. These are our Beaufort County clinical campuses. These are our Jasper County campuses, and these 2 are our Hampton County campuses. And our school-based clinics are not pictured here, but they are found within the 9 schools that we serve. Our clinical services that we provide include pediatric medicine, adult medicine, obstetrics and gynecology, dentistry, nutrition, behavioral health, and radiology. We also have a same-day clinic that allows patients to be seen immediately without having an appointment scheduled, in addition to a migrant health program that serves our migrant farm worker population and their families. As you can probably imagine, many of our patients with diabetes are identified from the providers within these various departments, whether it be a pediatric or an adult patient with diabetes, or even a gestational patient with diabetes. We are able to identify and serve them in ways that can maximize their diabetes care. We also have a sliding scale fee for those who are under or uninsured. And this is very critical for reaching those who are the economically challenged members of our population whom we aim to prioritize in our healthcare model. In addition, we have a 340B pharmacy that provides medications at discounted rates for our patients, which is especially valuable for our patients in need of various medications to help them manage their diabetes diagnosis. We also offer transportation to certain clinics in our system, which can alleviate the barrier of not being able to make an appointment due to transportation issues. For our patients who have diabetes and concurrently manage a diagnosis of HIV, we also have our Ryan White team that is excellent at ensuring that these members of our population are well cared for. Our patients with diabetes also have access to foot care, bundle eye exams, dental services at 4 of our locations, behavioral health services, and medical nutrition therapy or nutrition counseling. We also have recently become recognized by the CDC as an accredited provider of the National Diabetes Prevention Program. And this is for individuals who have been diagnosed with prediabetes. This program involves a trained lifestyle coach who actually facilitates 12 months of classes regarding nutrition, exercise, and emotional well-being in an effort to prevent or delay the onset of type 2 diabetes. And lastly, we are an accredited provider of diabetes self-management education, which, as you know, is the primary topic of our discussion for today. Now, BJHCHS gained accreditation status in 2014, which has allowed us to bill for our diabetes education services. There are 2 accreditation organizations, the American Diabetes Association, or ADA, and the American Association of Diabetes Educators, or AADE, which is who has accredited us. Diabetes education, or DSME, is considered a covered benefit when provided by a diabetes educator within an accredited program. It is partially covered by Medicare and certain insurance plans. Now, there is some alphabet soup involved with the billing aspect. The Center for Medicare and Medicaid Services refers to DSME as Diabetes Self-Management Training, or DSMT. So you may hear this referred to as DSMT instead of DSME, but the terminology does reflect the same program. There's also a nationwide push to include support in the title. So you may also see diabetes education referred to as DSMES, or Diabetes Self-Management Education and Support. And again, all three terms are interchangeable and can be used according to your organization's preference. I should also mention that this year there is a bill proposed in Congress to expand coverage, and it's called to DSME, and it's called Expanding Access to the DSMT Act. So be on the lookout for this as well. It should help reduce Medicare or increase access to Medicare beneficiaries. So if your organization is looking to start an accredited DSME program, it is expected that you abide by the national standards for diabetes self-management education, regardless of whether your accrediting body is ADA or AADE. As of now, the 2017 standards are the most current, and they are updated every 5 years. It's a guideline for starting and operating your DSME program, and these standards must be met in order to bill for Medicare, and annual documentation is one of the many requirements to demonstrate updates and the review of your curriculum. There are a total of 10 standards that must be met or achieved in order to maintain a successful and reimbursable DSME program. We'll walk through them right now to introduce them, and we'll get more into detail as we progress. First, it's important to define the structure of your program within your organization. Next, you should identify a list of stakeholders that can support your program from the ground up. Early on, you must also evaluate your patient population if you have not already done so. Next, you must secure a DSME program quality coordinator and a DSME team to follow. Move this over here. And the quality coordinator and team will help play an integral role in achieving the next standards, which include securing a DSME curriculum and individualizing the program to your patient population, as well as assigning resources for your ongoing support of your patients. And the last two standards include monitoring patient progress and developing a system for quality improvement. As mentioned, these standards will not only help to initiate a program, but will serve as a framework wherein you will repeat these steps as an ongoing maintenance process. So now Susan and I will dive into each standard in a bit more detail, as well as the documentation required for each. So that first standard involves creating the internal structure of your program. This means defining the role of your DSME program and what role it will play in your overall organization and how it will be designed to meet your patient's needs. I'll now turn it over to Susan, our quality program coordinator, and she will tell you a little bit about the documentation requirements.
This documentation requirement is what you need to provide in the review process, which, by the way, can happen at any time. Usually it's going to happen at least once in your 4-year period, but annually any program can be evaluated. You need to have documentation in your organizational chart. The DSME program actually fits into your organization. You need to have a mission statement defining the purpose with goals for the program and how it fits into the overall mission statement for the supporting agency. And you need to have a letter of support that should be submitted from a CEO, president, supervisor, or some such. In our case, we have a letter of support from our CEO, and I will say we have obvious internal structure, documentation, and support, and the fact that there are 3 dietitians slash CDEs working this program currently today.
That second standard involves garnering stakeholder support or gathering information and ideas from your stakeholders to keep your program relevant and effective. You should have a plan in place for how to use your stakeholders whenever an issue might arise. So for instance, if you have a new program and your referrals to the program were low, your stakeholders would be the ones who you would want to turn to for brainstorming solutions to that problem.
Okay, stakeholder input documentation is something that you get as a result of your advisory committee meetings. And that's another requirement that you kind of have. Those committee meetings have to be at least annually provided, and you need to have in those meeting minutes a list of the identified stakeholders and their specific role and reason, kind of like why they would be there. And to give you an example of this, our meetings are going twice a year instead of once a year, and we have a provider, we have a patient with diabetes on it. We had somebody from our EHS system, we have somebody from nursing, someone from the front desk, and someone from billing, all coming to these meetings as we work to further embed ourselves into our system and improve the services that we provide. It's been a very effective tool and very helpful process to undertake.
And next comes evaluating your patient population. So you must assess your patient demographics, needs, and barriers to care, particularly among those with diabetes, because knowing your population will help you forecast problems and generate solutions prior to even beginning your program. And it will also help you to better accommodate the program to meet your patient's needs.
Okay, so we have, of course, done those kind of evaluations, and we have them available for review whenever they're needed. We have the demographics for the area, allocations of resources to meet the population's specific needs. And in this area, I would say we have Hispanic materials that are geared for both Creole and Mexican kind of bents. We have materials available for people who cannot read or have difficulty reading. We have quite a variety of materials to meet needs. And we have, I think you may note in the previous part of our talk, as a system, we have actions available to overcome access-related issues or problems that we have implemented for people as they go through the program. Sorry. We looked at our patients last year, not just the patients who went to the program, but all of the patients that had diabetes in our system. And we found that 74% of them were African American, 18% white, and the rest either unreported or Asian Pacific Islander or American Indian, which was kind of surprising. The patients who did report told us that 10% of them were Hispanic, as opposed to non-Hispanic. But interestingly enough, I know that some of those speak English very well. And we had another 10% report that they only spoke Spanish. So I believe there's a good part of that 5% that is part of our Hispanic population as well.
And moving on to our fourth standard, your program will require a quality coordinator who will be in charge of collecting and evaluating data throughout the program. This data will aid in quality improvement efforts by identifying gaps in the program or areas for improvement throughout the spectrum of diabetes care in your organization as a whole. The coordinator can also serve as a source of feedback to the rest of the DSME team.
Okay, so in that evaluation process, we have to keep on record the coordinator's resume or CDE, and there has to be evidence in the whole body of information that we provide of ongoing oversight, implementation of standards, evidence-based services, appropriateness of program intervention, and the annual quality improvement plans. As we go through this, you're going to hear about all of that. It is required that we have the documentation of a minimum of 15 hours of continuing education credit for any of our team members who are not certified diabetes educators, and for those who are either certified diabetes educators or have the BCADM certification. We need proof that they are current in that certification process.
In addition to your quality coordinator, you need a team of diabetes professionals and perhaps paraprofessionals who can provide DSME or services that support the DSME curriculum. Generally, DSME providers are nurses, dietitians, or pharmacists, and often, like Susan said, are certified diabetes educators. There is also the opportunity to have paraprofessionals who can lend support by instructing, reinforcing self-management skills, facilitating group discussion, or providing ongoing support as long as they have performed and documented continuing education.
So the documentation required for review is that we can show them that we know that our, if we use a paraprofessional, they are meeting their scope of practice, and that our professional is doing that as well. In addition to that, if we identify needs out of that scope of practice, we need to have a system in place to address those. At least one of the team members needs to be an RD, a nurse, or a pharmacist with training and expertise pertinent to DSME or that have that advanced certification. So we need to keep current credentials available for each professional team member. That would be licensure, registration, certification, any of that kind of thing. And our particular team is made up of 3 dietitians, 2 of whom are certified diabetes educators, and 1 of whom may soon become one. 15 hours of diabetes-related continuing education annually is required really of all team members, because that's pretty much what a CDE needs to maintain to keep that status current as well.
And your DSME curriculum should be tailored to your patient population, but it must be evidence-based and must meet certain core areas that we will discuss later on in this presentation. It is important to consider that you might need more than 1 curriculum depending on your population. And Susan spoke to this a little bit earlier, but our program currently has 3 different curriculums, 1 for English-speaking patients, another for Spanish-speaking patients, and 1 for those with learning disabilities or any cognitive issues. And your curriculum should also be supplemented with any appropriate resources and educational materials.
So the curriculums have to be reviewed annually, and they should be updated as needed to reflect current evidence, practice guidelines, and cultural appropriateness. This is a process that takes place through our advisory team meetings, but we also, as I said, enhance these curriculums with added materials appropriate for individuals within the class environment. That individualization is also required in the next slide.
That's right. So your program structure can be flexible to meet the needs of your patient for individualization purposes. It is most important that the DSME providers assess and support each patient in an ongoing manner throughout the program to evaluate how to proceed through the curriculum with that individual or even a group of individuals in mind. This includes, but is not limited to, the communication style that is found to be most effective for that patient or group of patients.
Documentation of this would be in a de-identified printed patient chart. And that printed patient chart has to have evidence of the ongoing education plan and behavioral goal setting with follow-up, and that's something we do at each session. I've got to say this was a bit of a challenge when I first saw it because I'm so used to looking at materials within the computer that once I started printing them out, I realized I actually needed help of our EHS computer team and getting those charts to print out more reasonably. There has to be evidence that the assessment is performed in health status, psychosocial adjustment, learning level, and lifestyle practices. And as I said, it took a minute to get that accomplished.
All right, for our 8th standard, ongoing support should be provided however you see fit. Resources and activities should be made available to the participants so that they can self-select which of those resources and activities might be most appropriate for them. And this might be decided in collaboration with their DSME provider, depending on what their needs might be.
Okay. So again, that de-identified chart needs to include documentation of self-management support options and resources specific to the community with participant preferences noted. In that end, we have developed some resource lists for our 3 counties in terms of activities available that support active lifestyle or healthy eating, and we're always looking for more things along that line.
Participant or patient progress is a major component of the program. The 9th standard requires that patients set goals that DSME providers can track over the course of their participants' participation in the program. And these goals provide direction for the patient, but they also can demonstrate the benefits of the program as well as its successes and relevance.
All right, so the de-identified chart has to have at least one SMART behavioral goal with follow-up and measured achievement, and at least one clinical outcome measure to evaluate the effectiveness of the intervention. We actually have an Excel tracking sheet that we use to report overall how the program is doing, and so we know that we are setting goals in all 7 areas of emphasis, and we know how we're doing with outcome behaviors and track that way. And communication back to the referring provider also needs to be documented as effective for all Medicare providers. And in our system, our providers can read every note that we have, because we're in the same system. Within that system, we have a flagging system to be able to send a note to the provider if we can't see them face-to-face about any issues that we might identify in our sessions. And maybe they don't have a current meter, or they want to talk to them about medications or have some specific questions, we can do that. However, my favorite communication is face-to-face. If I can do that, we can be very effective in getting things done. It's one of the main benefits of being in the clinic, right there.
And quality improvement is the final standard and truly an ongoing step in the process. Headed by the quality coordinator, this involves measuring program effectiveness, identifying areas for improvement, determining timelines and even milestones, and presenting results to the team and to the organization at large.
Okay, documentation of quality improvement. This is going to be a process to collect that. And as I said, we have an Excel sheet that we fill out for all of the clinical data, and also that I use to track hemoglobin A1Cs before and after, so that we can report on that. And that is annually reported to the advisory committee, as well as the American Association of Diabetes Educators, and to our quality improvement team within BJHCHS. We also have to document the continuous quality improvement project, measuring effectiveness and impact of the program, And the advisory committee as a whole, part of their function is to identify areas of improvement and then hear reports on that annually. Okay, sorry. The next part of our section is to define what diabetes self-management is anyway. You know, what the heck is it? And I thought it would be fun here to take a minute to let you guys in on this and find out what you think it might be. So what do you think diabetes self-management education is? Is it a session about nutrition and exercise, or sessions about that? Is it a series of classes that cover the 7 self-care behaviors? Is it educational sessions accompanied by goals that are tracked over time? Or is it both B and C? What do you think?
So we're looking for those results here. Okay, it looks like most indicated choice D, both B and C.
Right. Well, you guys know things, don't you? I wish all our providers could do just as well as you do. Well, yeah. So diabetes self-management education is a formal educational program that helps individuals manage diabetes through 7 healthcare behaviors. And these have a great deal of research behind them about their efficacy in helping patients with diabetes make it through behavior change. The first one has to do with making healthy choices, specifically around carbohydrates at mealtimes or at any time, truly. It has to do with being active to lower blood sugars, both directly after you're active and therefore after that. It has to do with checking blood sugars, not just checking them and not looking, but looking at those numbers to learn from them. It has to do with setting up plans where you actually do take your medicines as prescribed, or if you cannot tolerate them, you have those difficult conversations with the provider to find a version that works for you. It has to do with problem solving for any of these areas to actually achieve the results in your life that you want. It has to do with learning about the importance of coping with stress and how this benefits blood sugar control and overall disease management. And it has to do with learning strategies that reduce your risk for any of the many multiple complications that are possible. So, people with diabetes have an opportunity to spend 10 direct educational hours in a year with a diabetes educator. The system is set up with the idea that that first year, at least this is what we do, that first hour is going to be that individual assessment, and the rest are in group or individual sessions depending on what's available at that site. The diabetes educator support providers in improving outcomes for people beyond standard primary care. And I think one of the major things is not only the material that we have, but the amount of time that we spend to really talk about issues that are of concern to them. Now, this is research-based. Classes help people with diabetes learn basic information covering those 7 tenets of self-care behavior, and they help them learn how to incorporate diabetes management into everyday real life. We also cover understanding how to use the devices that they have, starting with the blood glucose meters or insulin pens or syringes. Some diabetes educators go into insulin pumps. We, as a practice, are using the Vigo delivery device, not currently pumps. You see those more with endocrinologists. And also continuous glucose monitors can be run through diabetes educators. We're not doing that one yet either. They help with adopting healthy eating and physical activity habits, with nutrition education, information about meal planning, strategies for how to exercise, particularly with issues like arthritis or weight, things like that. And we can provide some limited weight loss support. The benefits to the patients. In my mind, the real benefit here is when you lower blood sugars, quality of life improves. When you can think clear, and when you can address life with a healthy mind and body, life is so much better. Studies have shown that people who receive diabetes education go to the doctor more often. They go there routinely, and they go for the care that they need. They take medications as prescribed, and their blood sugars, blood pressure, and LDL cholesterol are in much better places. And they have overall lower healthcare costs because of these habits. It helps patients improve their health outcomes by improving their self-management skills, or I think about this as self-efficacy. That was all the rage a couple of years ago, but that's what you see. You see people come in tentatively and leave with confidence, knowing what it is that they can and will do. It promotes improved metabolic control, lipid levels, blood pressure readings, but also quality of life, happiness, all kinds of powerful, positive outcomes. It can help people delay the onset or progression of diabetes for those with insulin resistance. And I think you all know the patient that comes in and says, okay, I've got it, I don't ever want to be on insulin. Well, they can achieve that. And I've seen people who get it and push their numbers back into pre-diabetic ranges and stay there. That can happen too. It's awesome. It will help in the tracking and monitoring of patients' progress over time. It can increase provider-nurse efficiency. Again, that time kind of amount that we have can help so much. And of course, because we're in the clinic, we'll feed any issues directly back to either the nurse or the provider to get them addressed directly and quickly, which can make a real difference. And it can meet pay, performance, and quality improvement goals, specifically related to patient-centered medical care homes, and really make a difference to programs overall. Okay, we've got another poll question. So I want to know if you were listening. What are the benefits of diabetes self-management education in a clinical setting? Does it A, maintain a built-in tracking and monitoring system for patient progress? Does it B, delay the onset progression of diabetes for people with insulin resistance? Does it C, increase provider-nurse efficiency? Does it D, make pay per performance and quality improvement goals? Or E, all of the above?
Okay, it looks like 100% selected D.
They were listening. That was an easy one. You did so well. All right, how do we get back? There we go. So now, the need for diabetes self-management education.
As Susan touched on, we know diabetes education is effective, but is it being utilized to its fullest potential? Nationwide, there is a greater need for diabetes education and the demonstrated benefits that it can provide to persons with a diabetes diagnosis. In fact, it is a nationwide focus identified as a Healthy People 2020 priority. Per the D14 objective, HP 2020 calls for an increase in the proportion of American adults who receive formal diabetes education from 53.1% to 62.5%. In your slide handouts, it says 56.8%, which was a previous number, and this new number is actually reflective of the age-adjusted total from 2012, which is the most recent number I have found. Moreover, there is a national standard recommended for all federally qualified health centers and patient-centered medical care home organizations, or PCMH organizations, to have more diabetes education offered to increase the number of patients with a hemoglobin A1C measure lower than 9%. And this is a measure that the Healthcare Effectiveness Data Information Set, or HEDIS, calls for. And it's important to note that DSME is also considered one of the top 4 approaches to lowering hemoglobin A1C values in patients with diabetes. So that just goes to show that starting a DSME program will likely assist any organization in meeting these priority areas identified here. A 2017 study on 1-year outcomes of DSME among Medicare beneficiaries who were newly diagnosed with diabetes found that less than 5% of Medicare beneficiaries are actually utilizing their DSME benefits. So this signals that DSME is a severely underutilized service nationwide. And among all reporting states in Healthy People's state-level data from 2015, 47% of adults with diabetes had not received any form of diabetes education, and an age-adjusted total of 52.6% actually did receive diabetes education. And this is an increase from the numbers included before in the slide handouts, which reflected 2010 data, but this is 2015 data, more recent, and it shows that we're moving in a positive direction and we want to continue this trend. A higher prevalence of DSME programs can change these statistics by means of having more opportunities for diabetes education across the nation. Now again, Beaufort, Jasper, Hampton Health resides in South Carolina, where 61.8% of adults with diabetes have received formal diabetes education. And this is above the national average, but it is 0.7% below the HP 2020 target of 62.5%. And here on this slide is a quick visual of the reporting states that have either surpassed that target or are close behind it. So if you hail from one of these 11 states, you likely have some excellent programs in your area that are offering diabetes education and may serve as a resource for you in beginning your own program. I know we might have some listeners from Oregon, Washington, South Carolina, and Illinois, and you guys are on this graph. So I would encourage everybody, whether you're on this graph or not, to visit the ADA or AADE website for listings of accredited DSME programs that are in your state to start finding some resources. As we touched on earlier, the 3 counties that BJHCHS serves are quite rural, and so access to care in these medical areas can be limited when compared to other urban or suburban areas throughout the state. And this may hold true for several of our viewers today, regardless of which state you might be in. If you're in a rural area, it's likely that diabetes education is not largely accessible to your patient population. Yet, diabetes education is especially important among these rural residing individuals to ensure glycemic control, because these individuals are at high risk of developing diabetic complications.
Beaufort County, as you can see from this map, is just a grouping of a bunch of islands. And for those patients out here without a lot of money, navigating those islands to get care can be quite an issue. It's beautiful to look at, but you can't swim through it, you know. Jasper County is a very rural county with much less resources even than Beaufort County itself. It is primarily farmland and just a lot of land. So it also can be problematic in terms of getting to care. Hampton County, similarly, is a lot of small towns, really small towns. There are no big towns at all. Hampton being the largest with a very small hospital. And it doesn't have a lot of resources for people who are, say, in Estill or farther away. And we are delighted that we have offices there and that we go there. So, but why is it that people don't use the resources that are even available to them? There was a study done by the American Association of Diabetes Educators where they called people and they asked them. And, oops, I'm going the wrong way, sorry. Excuse me, sorry. So people with diabetes, when they got the referral, they didn't follow through on it. They may have been shocked or in denial about the whole diagnosis. They may have had family and friends giving them advice that they thought was credible and appropriate and all they needed, or they thought they could get what they needed from the internet, or they thought they just knew what to do to handle it, and so they didn't come. Primary care providers, they do know the importance of diabetes education, but they don't necessarily think to prescribe it or prescribe it definitely enough, meaning they let the patient know that this will be valuable to them and it's worth their time, effort, and money to come. Once they've made that referral, they may forget to follow up with patients to see if they actually kept the appointment, because as we know, people with diabetes often don't. And encourage attendance for them to come. And of course, they have such limited time. This is totally understandable. So the outcomes that we track in our program are changes in hemoglobin A1C, and we are going to share our data at this point, as well as the percentage of people who met their goals that they chose. And these are the people who went completely through the program. You can see the various years that we have here. In 2015, we had a 0.84% drop. In 2016, it was 2 and 1.88 in 2017 and 1.9 in 2018. These are the self-behavioral goals. This is from 2015, and we noticed this was a small number that we were looking at. This is from 2016, where we got a little more variety in our topics, but still not quite where we wanted to be. This was 2017 with more people, and 2018. Okay. So this is how they kind of tracked out in terms of those that met the standard of patients achieving at least 70%. Now, when we had really small numbers, we could kind of, explain how that happened, but still we were disturbed by these low numbers as a group. And the advisory committee and I decided to take this on as a quality improvement project for us. I am so sorry. Okay. Where are we going? Okay. Which I wasn't supposed to say yet, because I wanted to know from you looking at the data what you would take on, because there were quite a few opportunities in there that you may have noticed. So would you have increased program participation, improved goal achievement, expand the variety of goals from which to choose, improve program retention, or all of the above? What do you think?
Okay, it looks like most selected D, all of the above.
Okay. What was the second most? I can't really see.
Perhaps it was that first option, increased program participation.
Interesting. Okay. Well, as a group, we decided we could only do one at a time. So the first one that we chose was to improve patient goal success. And so we searched for a training and all staff attended. We determined that the behavior change model was a powerful intervention that we could use to improve the way we framed our goals, to try to make them more effective and modified them to meet the people where they were. And that seemed to be really helpful. This documented an increase in goal accomplishment and improved the A1C drop along with other outcomes. But as you can see, the second program improvement effort that we chose was to increase program participation. And we identified key issues that seemed to be leading to that. We had referral system struggles in that the DSME program required different appointment times than the MNT. It was a different program, and understanding about that seemed to be problematic. And then we had problems with people remembering when we were coming to do DSME schedules and keeping up with that. It was somewhat confusing in the beginning. There was limited transportation for those in rural settings and high costs for patients without full or partial coverage. So our first effort was to target both providers and front staff understanding of what the DSME program offers and its breakdown of class topics and how diabetes self-management differs from the medical nutrition therapy that they were used to us providing all the time. The things that we did to change was we made each site have its own repeating schedule that they could know just by knowing that the first and third Wednesday we would be there. We did targeted marketing both to providers and front staff. We had discussions individually and with both of those folks. We had marketing materials that we used to explain more about the program that I actually got for the American Association of Diabetes Education. And we have an override annual staff meeting where we did a presentation providing some of this information that you just saw about our outcomes and what the program is about. We improved the provider ordering system in the EHR to make it easier and simpler for them to order the program at all. And we got support from our management to have a person available to call patients a day or so before they were scheduled to come to remind them to come, which was powerful. And we got assistance with accessing transportation and using some of the systems within our overall BJH family to address needs as they were identified.
As we continue to monitor and evaluate our program progress, we have planned for our DSME providers to attend care team huddles at the start of each day to make our presence known and to learn updates and review patient progress with the primary care team and providers. We have also created and plan to disseminate informational brochures that detail how our DSME services differ from the medical nutrition therapy, or MNT for short, and to just describe what the DSME services are for staff and patients. We also plan to administer provider satisfaction surveys and surveys for class dropouts to receive some feedback about our program and how we can improve. We will also be offering additional support sessions into the program for class graduates as a nod towards that recent shift towards both diabetes self-management education and support, as we mentioned earlier. And lastly, our organization has initiated a diabetes case management program that we expect will actually be a source of additional referrals to our DSME program. Now for that big takeaway, there's a greater need for integrated chronic disease management programs, such as DSME programs, throughout the country. While primary care is essential, additional opportunities outside of immediate primary care for self-management education can only improve patient outcomes and that self-efficacy component. Moreover, more opportunities for diabetes education will help achieve the Healthy People 2020 objective to increase diabetes education and the HEDIS measure to increase the number of individuals with an A1C below 9%. On this next slide is a list of our references used throughout the presentation, and this can of course be found in the handout that was provided to you. And this concludes our presentation for today. So at this time, we would like to welcome your questions. And if we don't get to all of your questions today, we will be able to answer your questions at a later date via email. So go ahead and please take the time to submit your questions now. And I believe Sylvia is going to help us out with that.